topic, and this is GI cancer management tools. And I am so pleased to introduce one of our outstanding board members for the Ruesch Center, Lee Jones, who is a stage 4 colorectal cancer survivor and an amazing research advocate and quite experienced in the space of clinical research. And Dr. Marcus Noel, an associate professor at Georgetown, who also oversees our clinical research office.
So good morning, and thank you for joining us today. My name is Dr. Marcus Noel. I'm a GI medical oncologist here at MedStar Georgetown. I'm honored to be joined with Lee Jones, who is a research advocate and stage 4 colon cancer survivor, and also a Ruesch Center Advisory Board member. Today, we'd like to just share some things that we think patients with GI cancer should know about as a resource tool. Hopefully you'll find this to be helpful. I'll start, Lee, as a 15+ year cancer survivor. What do you wish you could go back and tell yourself when you were first diagnosed?
Yeah, thanks, Dr. Noel. I appreciate being invited to attend this. I'm at O'Hare Airport waiting for a flight back to DC from the ASCO annual conference. So if there's noise or people coming back behind me, that's why, and that's where I am. So I actually spent 18 years since I was first diagnosed in 2004. And I've got to say, I knew absolutely nothing. I've been in a hospital twice in my life when both my sons were born, and that was it. I had no family history of cancer. I had no members of my family that had cancer or died of cancer, certainly not GI cancer or colorectal cancer. So I was at a clean slate. And you also have to remember that the whole environment for patients was totally different 18 years ago. I mean, patient-centered drug development didn't really exist. Patients weren't really listened to. We were basically told, here's what we're going to give you, and that's what we got. And of course, the survival rates weren't very good back then. I remember coming back from my colonoscopy where they discovered the tumor. And of course, we checked with Dr. Google, who said 5-year survival rate from metastatic colon cancer was 7%. So that's kind of, mind shaking when you hear something like that. But my attitude was always, I don't care if no one else has survived, I can be the first one. If one other has survived, I can be the second one. So 7% didn't really faze me. And what I call a drug triplet, when I was getting 5-FU, oxaliplatin, and just been approved a drug called Avastin or bevacizumab. Really had been approved a month before I got diagnosed. So, I think the combination of those 3 drugs was really useful for me. The biggest thing that really concerned me is, so after my first 8 rounds of chemo, colon resection, and then 8 more rounds of chemo, I had a clean CAT scan, and so I was what's called no evidence of disease, and I thought I was cured because nobody told me that chemo doesn't cure colon cancer. And so I was merrily going along my way, getting CAT scans every 3 months, still no evidence of disease. And a year later, it had come back into my liver. So I think that was more shocking than it would have been if I had known to expect it. I mean, really, it was expected. I mean, many fewer than 10% of people actually get cured from the chemo. So that was kind of the biggest thing that surprised me. But I mean, those are things that I think are pretty easy to tell a patient about, things to expect. And I know now with comes where they actually can study in clinical trials what those side effects, not only clinical side effects, but how it is perceived by and affects the patient individually. That information is really important for patients to know, because I think we can withstand a lot of things as long as we know what to expect. And it's the unexpected that makes us wonder, well, what's going on now? So I think those are the major things that I was thinking of that I wish I knew about. I mean, also kind of that people do survive this now. Your life is stopped. I went and got a will signed, make sure I had life insurance. And those sorts of things are important to do to make sure that your family is taken care of, no matter what the outcome is. So just recognize that nobody really knows for sure, that a lot of what doctors will tell us is based on statistics. And even though there might be a 7% chance of 5-year survival, nothing says you're not going to be one of those. So try not to listen to that stuff. Just be willing to take as much as you can, because the drugs they're giving you are the best drugs that they have available to help with your disease. And even if it can't be cured, extending your life opens the opportunity for a cure to be identified over time. I mean, who would have thought 18 years ago that immunotherapy drugs would actually be saving cancer patients' lives? And there are cancers now that are very curable, that never used to be. So, drug development is coming along very well. People are surviving longer. The longer you can survive, the better the chance that you might find a cure.
Thank you, Lee. I often hear patients, when they're first diagnosed, they haven't been sick for ever in their life, and so then they're thrown into the medical system with a difficult diagnosis, and you're kind of not sure where to go, especially with a advanced cancer diagnosis. And then with cancer, as you mentioned, the chemotherapy drugs can have many side effects, and we always don't do a great job as physicians of warning of the potential adverse events, and it can be very troubling to experience these and not know exactly what's happening. And then the stats, they're stats, but they don't apply. Every patient is different, and so if you do hear stats from your physician, you have to just understand that doesn't mean that's going to happen to you, and so you always want to remain hopeful and optimistic that you are going to do well and have a good outcome. And the financial piece, yes, we always want to, that's why we want to loop in social work and others to help with that avenue. But the financial toxicity of cancer and the burden that it places on you as an individual patient is quite big and large. So I think you brought up many good points, Lee. You brought up clinical trials. What do you think patients should know about clinical trials when they're diagnosed, or even after they've had cancer for a time? What would you want them to know about clinical trials?
Well, there are a couple things. There are basically 3 basic phases of trials. So when you hear about a clinical trial, they're not all created the same. The very first phase of the trials, all they're trying to do is look at what the dosage might be that patients can tolerate. It's called the maximum tolerable dose. And then that dose is used in the so-called phase 2 trials, where they're trying to see whether the drug has an effect on the cancer type. And those are basically generally smaller trials. And what you really probably mostly get involved in are the phase 3 trials, which are large trials. They're trying this drug on a larger number of people with various characteristics and backgrounds. So obviously, the earlier the phase is, the more unknowns there are. So they're also called the first in man trial, where the drug's never been tried in anybody, but they do years and years of laboratory work, animal work, before it ever gets to people. A lot of patients are concerned and maybe afraid of the so-called placebo. I don't want to end up getting nothing because I know I need something. Well, in cancer clinical trials, placebos are not used at all, except when maybe the standard of care is nothing, like after someone's gone through chemo and surgery. Whether there's chemo after that surgery or not, sometimes there's no benefit to it. So the standard of care is nothing. So someone might be trying a clinical trial of something versus that nothing, and then those people getting nothing would get a placebo, but that's just what you would get if you weren't on a clinical trial. So I think for a lot of people, especially people that have not found an effective treatment up until then, a clinical trial may be their last hope of getting some sort of a positive effect, either reduced symptoms, longer life, or as we saw with some of those immunotherapy drugs, there were amazing results and people in clinical trials were getting cured, which is not the expectation that people should have, but it's a possibility. So, you have to compare it with what you'd be getting otherwise. And generally in those trials, one group would get the standard treatment and the other one would get something different, generally standard treatment plus something else. But you also need to remember that there's a group called the Institutional Review Board that every institution that does clinical trials has to have. And that IRB, as it's called, reviews all the clinical trials and make sure that the trials are safe for people. We can't, so I actually serve on an IRB at Georgetown, Oncology IRB at Georgetown. So every clinical trial coming through Georgetown, and I've seen some of Dr. Noel's clinical trial applications coming through, we review them. Now, most of the IRB is scientists and doctors, but there have to be unaffiliated non-scientists on the IRB. And in my case, I'm actually a patient on the IRB. So I'm even more interested in protecting any patients that are going to be going on those trials. Not a guarantee it's going to be effective, but the main things I look for is that potential harm is reduced and that there is full disclosure of everything you may deal with so that you can see what the risks might be and you can make a determination as to whether you're willing to go through that or not. They're not risk-free by any means. In some cases, they know pretty well what the side effects are going to be. Other cases, they don't. But I think as long as they tell you what they might be.
Thank you. Yes, it's every trial is not the same, and I think often patients may be it can be confusing about the phase of the trial and the fact that you have some trials where you're getting placebo, but in oncology, many where you're not getting a placebo. So just talk with your doctor about the clinical trial and be confident your physician is recommending, if they're recommending a trial, it's because they're recommending so it's in your best interest, not that they want to experiment or use you as a pincushion, but they think that the trial may potentially provide benefit for you, or it could be a situation where your cancer is more advanced and there really are little to no options that are standard that they can use. And so the trial is, for lack of a better term, the last option. But certainly trials are really important and we encourage patients to consider them when they are eligible.
Another thing too is every drug that's available has been going through a clinical trial. So that's how progress happens.
Yep, exactly. Lee, how can people connect with patient advocacy organizations? You are yourself, remain a strong patient advocate, but what tools, resources out there in the community? I know that there's some big ones like GI Cancers Alliance and Fight CRC, but how can people get information in the community, Lee?
Well, there is certainly, as compared when I was diagnosed with my treatment, there is an overabundance of information. So the most important thing is trying to find credible information. And there's a lot of information through social media that is not necessarily reliable and you really shouldn't pay attention to. But there are those advocacy organizations that make a real effort to provide real information that can make a difference for you. As Dr. Noel mentioned, Fight Colorectal Cancer is one of those GI Cancer Alliance for those that have many other GI cancers, not just colorectal. There's Colorectal Cancer Alliance, that can be confusing, two alliances. And they can also provide a connection with patients and survivors. So for a while, I was a buddy with the alliance. So if people had questions, they could actually talk to someone like me who had been through perhaps what they're going through now, who can help guide them or give them some more information about it. There are also organizations like Hope Connections that provide what we call complementary treatment. So, when you're going through your treatment, you could have pain, you certainly are going to have anxiety, and they provide a number of services that really aren't provided through cancer centers like Georgetown, Lombardi. Things that I had done, Reiki is one, meditation, Tai Chi, acupuncture. So those are things, and I don't know whether any of those really helped me get through my treatment or cured me, but they're certainly nice to have, and they're all provided free of charge. And I highly recommend you searching out what they have and finding something that is enjoyable for you and that helps you get through your treatment. Because getting through your treatment is the most important thing, and being able to get through it at kind of the highest dose that you can tolerate, because that's what's going to be killing the cancer cells. Unfortunately, with chemotherapy, a lot of the other cells are killed as well, but now they have targeted therapies depending on your mutational mutation that's causing your particular cancer that will not be chemotherapy, don't have those same effects that chemotherapy has. So don't worry and think, oh my God, I've heard so many bad things about chemotherapy, I can't do this. Well, there are alternatives, so it's really not something to be concerned about. But it is worth talking to your doctor about, how you're able to tolerate whatever your treatment is, because there can be alternatives.
Thank you, Lee. And I'll just add another example is PanCAN, the Pancreatic Cancer Action Network, which is a great organization involved with pancreas cancer research, but also advocacy group for patients. So I think we're out of time, but really I'm honored to do this panel with Lee this morning / afternoon. And thank you for bearing with us through our technical issues as we're all busy with returning from ASCO that we were all at this weekend. Really exciting meeting. Thank you once again.
Okay, thanks, Dr. Noel. I just had all my treatments at Georgetown, my chemo and my surgery. So you're at a good place.